Dear Shri Ganesh Prasad, Terry Prasanna, esteemed panelists and friends. So I have been asked to talk about the past, present and the future, and so let me straight dive into that. So first, the past. So going back about 40 years, or even a little earlier, patients depended on a general practitioner, GP, whose main means of cure was aspirin, steroids, and a harmless injection. Healthcare was delivered primarily through a government health system of primary, secondary, and tertiary care centers, which were often short of staff and medical infrastructure. This government delivery system was supplemented by private charitable hospitals run by church or philanthropists. Medical technology companies like yours could sell only if government hospitals were given the budget and private hospitals got the grants. Doctors had to fund clinics, X-ray, pathology lab, nursing homes from family savings. Hospitals, nursing homes and clinics could rarely get a bank loan unless they offered huge security, including personal guarantee. Absence of a business model on healthcare delivery left patients unserved, leading to enormous patient load on the government system and a few private hospitals and clinics. First pioneer to think of healthcare business on lines of financial viability was a banker educationist, doctor. It was Dr. T.M.A. Pai. He evolved the model of patient fee in a teaching hospital, plus medical school fees by students, plus capitation fee by parents, should make it sustain on its own income generation. This was the first time outside the government, in private sector, in India, a self-sustainable model was thought by this visionary Dr. T.M.A. Pai. And this successful model led to creation of a large number of teaching hospitals in South India. And this has been a great generator of healthcare personnel. It's not only Manipal, it's so many institutions came up, and we could not have had the number of radiologists, number of surgeons, but for this expansion of healthcare infrastructure which happened. And we should be grateful to him today. The second pioneer to dream offering clinical excellence at financially viable patient fee rates was none other than Dr. P.C. Reddy, who founded Apollo Madras in mid-1980s. But for these two pioneers, sustainable private investment would not have found the way into Indian healthcare. Rightfully, they occupy the number 1 and number 2 position in Indian healthcare today. Unmet demand from patients continued to rise as mere two private institutions, Apollo and Manipal, could serve only the top 20% of higher income families. Third pioneer to evolve a more democratic business model, I call it democratic because it was more widespread, was medical technology company aspiring to serve Indian healthcare market and build a sustainable business, and that was GE. The goal was offer accurate diagnosis at fee per scan, which Indian patients can afford. And that was a very, very small number, whether it was ultrasound or CT scan. what the Indian patient could afford was a fraction of what it would cost. So, accurate diagnosis meant in those days primarily X-ray, ultrasound and CT. Affordable fee per scan required product innovation, local manufacture, lowering product costs by more than 30%. Innovation in scanners suite or the X-ray room or the ultrasound room or the CT room, the cost of creating a scanner suite, innovation in that area brought the cost down, fee per scan, by 40% for doctors, clinics and hospitals. And the clinics and diagnostic centers played their own role because they took the responsibility to pay the installments through the income generated through patient fee, which was already low. So they worked 18 to 20 hours a day to see that the number of procedures done, the number of scans done was large in number, so the absolute amount of money was adequate to pay the installment back to the financing agency. So this was the model of affordable diagnostics, which I would say is the third major initiative which brought quantum change in the healthcare field. Innovation in financing medical centers was the next step to create large cadre of medical entrepreneurs into the interior India. Even in the early 90s, the banks would not budge from personal guarantees. Personal guarantee meant if your business was not able to pay installments, you have to sell whatever you pledged, and the biggest assets the doctors and others could give was their house or was their clinic. So basically that would be taken over by the bank and they would be on the road. And so very few people dared to take bank loans. So this is the time when Wipro Finance and GE Capital took the pioneering step and the risk of financing medical equipment on the basis of patient fees paying the installment. Till then it was security-based financing. It was the first time Wipro Finance took the lead to finance medical equipment on the basis of viability of the equipment generating enough surplus for the doctor or the hospital to pay back the installments for the equipment. And later, GE Capital played a very big role. And this was the third game changer. By the end of last century, most medtech companies adopted the model to serve economy markets like India. And this was the, I would say, the foundation of affordable and accessible care. Now I come to the present, and present I have defined for my talk as post-2005. So patient experience and service in the government health system continued to be unsatisfactory. In spite of huge investments in diagnostics in government hospitals, they operated at low utilization for one reason or the other. Either the equipment would be down, or they would not have the electricity, or they would not have the radiologists, or they would not have the health support personnel. So the utilization was low. So this was the time when business model innovation was done, which led to progressive state governments pushing the envelope, pushing their IAS officers to accept a new model. What was this model? It was a public-private partnership where the services would be rendered of diagnostics by a clinical service operator. And the government would basically give access to the medical facility, medical infrastructure which they had created, and the patient load. And the clinical service operator had to mobilize his own finance, which was backed by people like GE Capital. And clinical service operator had to negotiate and fix a fees with the government that both below poverty line patients who would pay only the for whom the government would pay only the government fixed fee, and the center would also do private patients who would be charged the market fees. And a combination of this would give viability. It was a risky model. It was a huge risk to the clinical service operator. There was a huge risk to the financing company. And there was a risk of this falling apart and failing for the politicians and the bureaucrats. But some of those state governments took the risk and moved forward with this model. And this gave birth to Krishna Diagnostics and other clinical service operator companies. Today, Krishna Diagnostics alone is serving 2,500 hospitals. Several million patients they see. And the model is so successful, Niti Aayog has prescribed it as a model to be followed. And I would credit GE and Raja and Ashok Kakkar for relentlessly pursuing this and finding solutions to so many obstacles which came in the way and make it work. So the PPP model was the fourth disruptive innovation which impacted and improved the government sector health delivery related to diagnostics. The fifth innovation I would rate is the innovation in cancer care. Molecular diagnostics gave an opening. Molecular diagnostics could accurately assess and diagnose the cancer and create a treatment pathway. So this was used as an opportunity to bring multiple stakeholders together. Cancer care chains, technology companies, logistic companies, financing companies were brought together to evolve a hub and spoke model where acute cancer care is delivered at the hub and diagnostic and day care at spoke. And a big role played by GE was to bring through innovation PET scan cost to a fraction of what it would cost, close to 40% of what it would cost. And several steps like that made cancer care accessible at the spoke to smaller cities and towns, and made cancer care closer to where the patient lived, and made cancer care more holistic and affordable. Now, I credit Terry for taking the leadership to make this happen, including she relocated herself to India to make it work, and a big acknowledgement of Terry in this whole disruption which was created. There is a lot more to be done in this area because affordability is still far from desirable. And unless the daycare centers do chemotherapy, unless the daycare centers do the radiotherapy at again a fraction of the cost of what it is today, we cannot say that affordable care has reached the people in the country. So I'm keenly going to listen to the oncology panel and find out what you have in mind in GenWorks partnership there. The sixth path-breaking innovation is the insurance. And this has come from government. Health insurance sector was open to private and foreign investment right in the late 90s. But unfortunately, it made impact only to top 30% of society. And little impact at the bottom. So, rupees 5 lakhs worth of hospitalization a year to a health card holder is what government launched under the Ayushman Bharat scheme, which for the first time has given some significant amount of money for critical care to the bottom 30% of the population. And this card can be co-branded with the state schemes, in which case this 5 lakhs can go to 8 to 10 lakhs, because the states also have their own scheme of additional subsidy. And I think this is a great, earth-shaking move for India. Now, you may know because you are in the field, but it's amazing that 24 crore card holders are there today. 240 million health card holders are there, and they consumed 43,000 crores of medical service, $5 billion. They're stimulating a huge demand for the healthcare sector. And Ayushman Bharat scheme has qualified 30,000 hospitals to deliver care. 14,000 of them, 45% of these hospitals are private hospitals. And 40 million patients, 4 crore patients were served, admitted into these hospitals. And more than half, that is 21 million, were admitted to the private hospital. For a company like GenWorks, this is a golden opportunity. Serving under the Ayushman Bharat scheme, the empaneled hospitals, which are by and large located either in the remote areas or located to serve the urban poor. So the ability to serve these 30,000 hospitals, out of which 14,000 are in private, I think is a big opportunity a company like GenWorks should grab. The seventh path-breaking disruption is digitization of healthcare. This again has happened phenomenally due to government initiative. COVID transformed India's smartphone penetration. Can you imagine there are 1 billion smartphones in the country today? 1 billion. The remote education delivery and need of a smartphone to register yourself under Arogya Setu forced citizens to go after smartphones and buy them. And many Chinese companies and Indian companies produce smartphones where a hand-me-down was available at 3,000 to 4,000 rupees and a new smartphone was available at 10,000 rupees. And this completely changed the digitization infrastructure at the micro level, where the individual can take initiative to access healthcare and education. Now, the other scheme during COVID which was launched was the e-Sanjeevani scheme, which is the teleconsulting. Do you know that 90 million consultations have been delivered? 90 million, 9 crore. And the Apollo system has delivered 10 million. So 100 million teleconsulting delivery has taken place, making India the largest telehealth network in the world. Not only that, I think even the creation of medical records, creation of COVID certificates, creation of immunization records has all taken place in a very quiet way, without causing too much of too much of halagulla in the whole system. See, an urban or a rural person could, using Arogya Setu, find out where he can get the immunization and which is the clinic or hospital nearest where appointments were available, and he could get an appointment which would say either the appointment is on this day, morning or evening. To that level of accuracy, to that level of mapping, the entire health infrastructure was mapped and it was made available to the common citizen. And then when he went there and got immunized, the certificate was loaded on his smartphone. So he could carry that wherever he went and gain access in the time when people without immunization did not have access. Now, no other country in the world could accomplish this, including United States. So digitization, what we talk a lot about it, but I think we're fortunate that crisis has brought a digitization into the country. And this is something which networks like Apollo are leveraging in a big way. And I think, again, GenWorks, which talks about connected care, has to see how this whole network can make a difference to their services. Now I go into the future. I'm not going to talk about what most people would talk, and you already know about the technologies which are impacting. But I would like to draw your attention to three things which will make an important difference. And these are not technology based. I think we should start with our primary customer, who is the patient. What is patient looking for? Patient is looking for speed of diagnosis, accuracy of diagnosis, and once the illness is diagnosed, he wants a quick procedure and he wants to get back to work fast. So these are not phenomenal expectations, but he is on a wild goose chase to find out who is the doctor who can give him accurate diagnosis. Which is the hospital which will not make him undergo unnecessary procedures, multiple tests. Which is the facility which will lower his anxiety to get well fast. So if you can serve the patient in any way to improve his satisfaction, I think there is a big demand for such a service or such a device. Now, you look at the hospitals today, they're full, they're busy, they're overworked. Still, procedure productivity is modest. Patient satisfaction can be much better. The big choke point today in hospitals is shortage of specialists and super specialists. Because digitization, Ayushman Bharat, and many enablers are bringing loads of patients to the health delivery system, but there are no number of specialists and super specialists required to serve them is in short supply. And so I think what is the hospital's number one priority is, can they increase the procedure productivity? If they're doing 10 heart surgeries a day today, can they do 20? Can they do 30? And if they're doing some other operation X, can it be made 3X, 4X, 5X? So if a company can contribute to this, solving this problem, even partially, or even in one segment, I think you have a huge opportunity. There is a lot of people who will come after you. Some of the ideas are that, triage the patient in the local secondary hospital and deliver specialty care from a super specialty team remotely using technology as a solution. I'm just giving you a concept. I know it's being practiced through robotics, this, that, and the other, but it's not easy in execution. And I'm looking forward to the tele-ICU panel discussion today to understand what you are thinking and how you are delivering in this area. The second productivity improvement that is coming in this area for procedures is single specialty chains. We saw Dr. Kshitij, 100 plus IVD centers. Can you imagine? In my early days, there was only one Indira Hinduja. And there was only one Kamini Rao, who we thought knows what IVF is. Now, single specialty centers, like what Dr. Kshitij has put together, 100 centers to manage it and to deliver service there, is increasing procedure productivity by doing clinical workflow as an assembly line, applying all modern management methods, they may not be calling it, but applying Six Sigma to remove all defects and to improve accuracy, to improve speed, and improve the number of procedures they can do locally and remotely. I think these single specialty hospitals, it's not just IVF, you take the care of eye care. Arvind Eye Hospital, Shankar Netralaya, and many of these people have adopted. And so I would say that at least they're able to double the procedure productivity. So I see that like CDR CT Center in St. John's Medical College Hospital in 1992, where the St. John Hospital gave away the radiology department to CDR to run all the procedures. And later they also gave therapy to Curie Hospital. Now you are going to see more and more of this. Multi-speciality hospitals will not be able to mobilize the number of specialists to manage the patient flow they're getting. A multi-speciality, let me tell you, has a lot of other advantages. But they will not be able to find the number of specialists. So a lot of such hospitals will be taken over, the departments, specialty departments, will be taken over by the single specialty companies. And they will be delivering service using the multi-specialty hospital infrastructure. So the question to me, to GenWorks, is that are you geared to make these chains successful in the hospital ecosystem? Having run health systems, I can tell you, one of the most complex workflow and most formidable and intimidating process and flow is in the hospitals. And there, if single specialty people who run at a certain speed go there and get frustrated and they come out, then I think, we are losing a great advantage. So if GenWorks can play a role of making them successful there, it's another opportunity. Now let me shift to a field where there is exponential growth, where I do not know whether GenWorks is playing. And this has grown exponentially in the last 5 years because of COVID and because of video calls. Video calls are done by grandmothers with grandchildren to patients with doctors to Zoom calls in the corporate sector, everywhere. And so everyone wants to look attractive and presentable on a video call. This is a global, huge demand. So facial aesthetics has become a multi-billion-dollar business. Fillers, abrasion, peels, home repair, and a remote medical guidance. Is GenWorks into LED, RF or laser-based devices for this segment? Do you market the magic wand? Have you heard of the magic wand? There's a company called Shani Darden, which makes this magic wand, which is one of the most popular devices being sold in the world today. What it does, it makes skin tighter and makes your face toned. So what a great demand for this device. So I think, these are some things which are happening which will make a huge impact, because when we think of medical care, we think of rehabilitation, we think of old homes, we think of mental dementia village, etc., etc. But look at the other end of the spectrum. Aesthetics is the big field which is opening up. The other last thing I want to say before I close is that what you may not realize is that under your nose, a great migration is happening. If you go to Africa, you will see the migration of animals seasonally. Just like that, a great migration is happening from rural to urban. And this is being encouraged softly by the government because, see, India cannot reach the levels of the third economy in the world, etc., only on population and by talk. It has to happen by reallocation of resources to the sectors which need them. The sector which does not need so many people has the highest number of population focused on it, which is agriculture and villages. So I think agriculture contributes to only perhaps 15% of the economy today, but has 35 to 40% of population engaged in it. And the only way economically wealth can be distributed is if this population can be engaged better in outside where they live today. And for that, urbanization is important. For that, creation of jobs is important in the urban area. And all models of economies has not been successful in creating those jobs in the urban area for them to move at the pace at which it's required. So, before they move to an industrial culture, the intermediate stage where they're able to earn a living is construction. So a massive investment is being put in construction by the government so that create jobs to move from rural to urban. And so this is happening already. And this is changing the architecture of India. And the greatest disruptor of this is Gadkari. By creating so many highways, by reducing the space and speed, he is creating a flood of people coming from remote areas, from Tier 4 cities, Tier 4 towns, into Tier 2, Tier 1, Tier 3. So if you are thinking that you can create a market in Tier 4, rethink. See, just look at the Mysore-Bangalore highway. It has disintermediated a lot of Tier 2, Tier 3 towns. Nobody will go to Mandya or Ramanagara or some other place in between. People from Kushalnagar or some place will come to Mysore and from Mysore to Bangalore. So is the GenWorks delivery infrastructure recognizing this pattern which will shut down a number of health facilities in Tier 3, Tier 4 towns where the migration of population it's not attracting. It may not happen in 1 year, but it's definitely happening in 5 years. So another person who is also contributing to this disruption is Vaishnav, an ex-GE person. He is again starting all these fast trains. So fast trains and great roads are going to create a big urban migration, and the byline of this company is affordable access. And so affordable access has to also be examined with this factor. So with these words, I leave you to think. It's exciting times for the healthcare sector. Agility, flexibility, agility in the business, flexibility to not just continue with the same old models of past success, speed, because that's what patient is looking for, innovation can help players to remain 1 year ahead of competition. If you want to grow and survive, what I have learned in the business is that all you have to do is that stay 1 year ahead of competition. Do something different. That differential should give you the additional zip. If you can constantly innovate to be 1 year ahead of competition, I think you have a great future ahead. Thank you.